Hi, welcome back to Take Us McGinnis Elder Law Hour. I'm Barbara McGinnis, and today we're talking about early onset Alzheimer's disease, and with us will be a physician. We're going to talk about diagnosis.
And I'm Tim Takis, and in this segment we are talking with Dr. Summers Chaffin. Pardon me, Dr. Summers Chaffin of High Point Family Wellness. And I think, Doctor, you were saying there's several clinics around.
That's correct.
I think you're stationed in Sumner County.
That's correct.
Your main question. And we're going to be talking about questions that you should ask your family physician, when you have a diagnosis or your loved one has a diagnosis of onset dementia. Thanks for being here, Dr. Chaffin.
Thanks for asking.
When we talk about younger onset dementia, typically what age are we speaking about?
It can start pretty much at any age. In my practice and in my experience, I've seen patients as young as in their 40s come in. Usually it's 65 plus, but we see a group of patients that do come in occasionally at a younger age.
And what does that look like? In other words, what are the symptoms that you're looking for or that you see, in a person with younger onset?
Well, what patients present with very often is they come in and say, "Doc, I'm not remembering things well." And I tell those patients they're probably okay, because patients who have dementia are not really concerned about it, unfortunately. They're almost always brought in by a caregiver, a family member, spouse who relates that that's a problem. And when I see that, that's a huge red flag that we've got a dementia type of process.
So normal people like me are 63 and are going, okay, where did I leave my toothbrush or something, or my phone? That's different.
That is totally different. Okay. And as we get older, as we progress in years, we all lose some learning ability function. That is, you get presented with some material, it's a little harder to absorb that. But when patients come in with a dementia type of process, they have a whole series of other things going on. Not remembering names is what's called explicit memory. That's not a problem. Not remembering who your family members are, that's a different situation.
Gotcha.
Totally.
Gotcha.
But would that be a later symptom, though? Does not remembering family names?
It can be early or later. In the early stages of dementia and in the very late stages of dementia, it's very difficult to know what kind of dementia it is. Yeah. We've talked a lot today, or I've heard people talk a lot today about Alzheimer's. Alzheimer's is just one part of dementia. It's only 60 to 70% of the diagnosis of people who have dementia is truly Alzheimer's. There's a lot of other things that are out there. There's mild cognitive deficit, where we see patients who start to lose a little bit of their cognitive function, but they may or may not progress on into Alzheimer's. We see patients with delirium, but that's a very acute process that goes on. We see patients with depression who come in, and that's a totally different type of presentation, but it all looks similar, and that's what makes it difficult to make that diagnosis.
But particularly for that age group, that 40, 50-year-old is starting to present with some memory impairment or other symptoms. Is that most often Alzheimer's, or is it all these other things too?
It could be any of those things.
Okay.
It surely could.
So maybe we shouldn't really so much talk about Alzheimer's, but maybe what the person's capabilities or incapacities are, and
because what patients or what families are looking for, what patients are looking for is something that is there something that can be done to cure this or correct this or make this better. And if you have something that what people would call a reversible cause for dementia, that's the sort of the goal that we're all looking for. And unfortunately, that's not very common. But that's the thing that we have to think of, especially in somebody who's young, because anybody under age 60 who presents with dementia, they've got something that is, potentially more than just a dementia type of process. There may be something underlying that's causing those symptoms.
So you're trying to rule those out first.
Right. Exactly. Things like blood in the brain tumor, thyroid disorders, depression. There's a process where you get pressure increases in the brain called normal pressure hydrocephalus. And those patients will present. And I had a patient who came in, and fortunately, he came in early enough that he didn't develop the dementia aspects of that. He came in where he couldn't walk, and he was having some urinary problems. And you put those three things together, and you know what you've got. And he was very, very lucky, very fortunate that he came in early. But those are the things that we're looking for in the younger patient, if at all possible.
So one takeaway, of course, is that don't assume that common memory loss has any significance.
Exactly.
Second, what I guess would be is it just because you get a diagnosis or think you've got a diagnosis, it doesn't mean that it's a death sentence or it's not reversible.
Well, hopefully we look towards that type of situation.
Gotcha.
Is it most common that the primary care physician is going to make the diagnosis, or would you bring in a neurologist or a neuropsychiatrist?
It depends on the patient. It depends on their age. It depends on their medical circumstances. Say, for instance, if you were to come in and your family said, "Well, she's lost it. She's putting her car keys in the freezer. She's not dressing when she goes outside." Those kind of things. Those are the kind of things that we would really, because of your age, we would be all over that to find out if there was a reason, for that. And the primary care physician, before he does anything else, would be really intent on that, and probably be bringing in a neurologist. If you've got somebody who's 92 years old who comes in and is just then starting to develop some signs of dementia, the primary care physician very often is in a position where they can take care of it. Also, the drugs that are being used are there's a lot of side effects and ill effects that can occur with those drugs. And before I commit somebody to some of those drugs, especially a young person, I want to get a neurologic consultation and evaluation.
So those drugs that you're mentioning, your Namenda and Aricept, right, or at least two of the drugs that you're probably talking about.
Correct.
Are they overused?
I think so.
Yeah.
I think so. I think a lot of patients are getting these medications that have a lot of, like I said, a lot of side effects, dry mouth, diarrhea, gastrointestinal disorders. Sometimes patients are falling with these things. Falling is one of the top 10 reasons that a patient over age 65 dies. And one of the biggest concerns about somebody falling is Alzheimer's or dementia, and also medication. So it's a perfect storm in that kind of situation.
So Dr. Chaffin, someone comes to you, the patient and let's say the patient's caregiver. We talked earlier about what questions family members should ask. What questions should they be asking you?
Well,
what you would like to see them ask?
Well, I'd like not so much ask, but to give me the history of what's going on with the patient, because I have a few minutes to see a patient. They have days, weeks, months, years of seeing what's going on with the patient. Interestingly, there are some patients, families, who don't pick up on this, and that's a sad situation.
Maybe another way to phrase that is, what do you want to know? I mean, the history. What's most important for you, for a person who's under age 65 that are presenting?
When did it start? What kind of symptoms? And how? Most importantly, how is this different than the way they used to be? You need to be able to determine and demonstrate that a patient has lost the ability to do something that they were able to do before. If they haven't, then you really can't make that diagnosis. But if you see somebody who used to be, for instance, a CEO of a company, a physician, a lawyer, a police officer, or whatever, who used to be in charge, who used to be really after what they were supposed to be doing, and if they come in and they're not able to do the things that they were able to do before, that's the kind of information that I want to know about.
So like when Kenna was talking about one of the early things that she noticed about Bill was he didn't know the steps to paint a wall. Couldn't hang a shelf and and then started having deficits at work that he'd done for 30 years. So it was very much part of his.
That's not normal.
That was not normal.
Whereas if I can't remember your name 10 minutes from now.
Yeah, neither one of us are going to worry about that, right? Yeah, okay.
Right. Yeah, because I was thinking we had a client too many, many years ago. He was an estimator working for a contracting company. He couldn't do the numbers.
Yes. That's called executive function. That is, if you can't do your checkbook, if you can't, do the estimates that you need to in your job, that's a huge component of dementia.
Right. Let's put your contact information up here.
All right, Sumner Station Family Wellness at highpointfamilywellness.com. Thank you, Dr.
Dr. Summers Chaffin, thanks for being here.
Thank you for asking me.
It's time for another break, and when we come back, we're going to talk about some of the other challenges of living with early onset Alzheimer's disease, and we'll be talking with some of our community resources. Stay tuned.